All right. So I told you in the last talk that TSC affects every body, every part of the body. And that's because every part of the body has genes, has DNA, and that controls things. We discovered these genes in the 1990s, TSC1 and TSC2. And then it was in the next 10 years that we learned what their job was to do in the body. What happens is that these two genes make a protein complex that has to work together. And this protein complex is the way that our bodies tell each cell to grow. It says you have enough food, you have enough energy, and you have the right instructions to grow. And so that's what these things are. Nutrients is the food, growth factors are the instructions, and energy is what uses that. And all of these go in to tell TSC1 and TSC2 what to do. And they do that through this other protein, which is like the engine, mTOR. And it's what starts everything from doing that it needs to happen to make the cell grow. If you don't have TSC1 or TSC2 because the genes are mutated, the engine is running all the time. And so the way to think about it is that here's the engine, this is mTOR, this is TSC1 and TSC2, and they prevent mTOR from running. In tuberous sclerosis, what happens is it's broken, and the engine is allowed to run away and cause problems. But we have medicine. We have a medicine called an mTOR inhibitor that can stop mTOR from running. This medicine has been around since 1960, and it's been used to treat cancer. It's been used to patients who have an organ transplant. It's used for that as well. It's used in the heart for people that have to have, you guys know what a stent is? When they have to put a tube in the heart to make a blocked artery open. It's used to make that so that those stay open and don't close again. And so one of them is called Sirolimus, and the other one is called Everolimus. And they're very similar, and we use both of them in tuberous sclerosis because that's what these are. And so even though the genes don't work, we can use Everolimus or Sirolimus to stop mTOR. And so the first study that we did was in the kidneys. Here's an MRI. Here you see a large tumor on that kidney. We gave them Sirolimus, and that tumor shrunk. And this is a graph that shows all the patients who took medicine. They took medicine and it shrunk. They stopped taking medicine and they started growing again. So when we treat patients with these medicines, we don't stop it anymore. We just put them on the medicine and have them keep taking it. Okay. And so we did this with a second study, and this is what we call a phase 3 study. These are the studies that the government wants us to do before they will approve a medicine. And this is where we have to give patients medicine or a dummy pill that has no medicine in it, called placebo. And if we don't do these type of studies, the government won't approve the medicine. This is the type of study we have to do. And so here you see two tumors. Here's one right here, here's one right here. Here they have shrunk down. These are the patients who took medicine, and you see almost all of them, the tumors got smaller. These are the patients who took the placebo. Some of them got smaller, don't know why, but most of them didn't change or they got bigger. And so this was the first treatment that we did outside of the brain. More recently, we looked at patients who had the cysts in the kidney. So all these little white spots are cysts. Okay? This is an angiomyolipoma. Here's all the cysts. We gave them the medicine, and they still have one cyst here, another, this is not a cyst, this is right here though. The angiomyolipoma got smaller, and all the cysts are gone. And so this is all the different patients who took medicine and saw their cysts go down in number, and they went down in size. Then we gave it for the patients who had the lungs, who had the lung disease. And in the patients who did not take medicine, their breathing ability to completely went down. These are the patients who got placebo, and these are the patients who got the medicine. Their actually lungs got better. They could breathe in better. And so these are two different measures from that. So today we want to talk about epilepsy and autism. What does it do for that? Well, this is a patient who had one of those brain tumors, had a SEGA. And what we see here is SEGA had already been operated on. So here's the cavity from where the surgeon went into the brain. And this is the tumor that grew back. The surgeon didn't get it all completely out. If the surgeon doesn't remove the entire tumor, it comes back. And so he started taking the medicine, and this is after 3 months, and this is after 6 months of him treatment. And this is the bar showing all the patients who took it for brain tumors, how they got smaller. Well, we did this also in a placebo-controlled way so that the government would approve the medicine. And these are the patients who continued to have growth, who got placebo, but none of the patients who took medicine had their SEGAs get worse. And these are the numbers. Those who took medicine, their tumors shrunk by half, 50%. Those who got the placebo, their tumors got bigger. They got larger. I'm going to skip this for now because we'll talk about side effects at the later on, okay? Just for time. So now I want to talk about what we do for epilepsy for this. We took 20 patients who had been on 6, 7, 8 different medicines. Some of them had epilepsy surgery, but they continued to have seizures. And we said, let's give them medicine to treat the epilepsy. So we had 23 patients that came to our clinic saying we want to do the study. 2 of the patients didn't have enough seizures, and so the study said you had to have a very minimum number of seizures, and it was quite generous. I think you had to have an average of 2 seizures per week, but 2 of the patients came and they weren't having enough seizures at the time when they got enrolled. 1 patient had never been treated with vigabatrin, and so we started them on vigabatrin instead of the study medication. But 20 patients were able to start treatment. All of them continued treatment for 3 months. And what you see here is that most of the patients lowered the number of seizures they had before. There were some that it didn't work for, but most of the patients that got their seizures got better. And we continued them to give them medicine. And this is what they did over the 3 months they took the medicine initially. And this is what they did over 5 years, or actually 4 years. They started up here on average, and then they came down here. Now, very few of them got down to 0, so it didn't make them stop having seizures completely. But it made them go from having 60 seizures in a month down to somewhere closer to about 10 seizures per month. So a lot better. But as every study, we have to now do the phase 3 design where they get the placebo, and then we tested 2 different doses. We tested a low dose of the medicine, Everolimus, and a high dose of the dose of Everolimus. And this is the response that we got. Those patients who took the placebo drug, this is how, they just because they came to the clinic more often, they did get some improvement in seizures. But the patients who took a middle dose or the patient who took the high dose, they dropped their seizures significantly over those 3 months. This is the number of days where they had no seizures in 24 hours. Here's the placebo group. Here's that medium group. Here's that high dose. So they had more days without any seizures as well with treatment. Now, one of the things that these patients, like I said, we don't take them off medicine anymore if the medicine's helping them. And so the patients were allowed to keep taking medicine in this study. And so we had about 30% of them that were able to cut their seizures in half or better after just 3 months of treatment. But that means that 2 of every 3 people, you can say the medicine didn't work. So we kept them, but they weren't having side effects, so they could keep taking it. And what we see is the patients who took it for 2 years, now we have almost 60% of patients responding to medicine. So this is after just 3 months, it's 1 in 3, and after 2 years, we got that to 2 in 3 patients can respond better. And so we think that's pretty important that it may not be evident right away if the medicine's helping, and as long as you're not having side effects, then we would recommend that you keep trying to take the medicine, because your child may not be in this group, your child may be in this group up here. The other thing that we learned is that it does work better the younger the child. So it did help, roughly about 1/4 of patients who were 18 and above. So it can help adults. But the patients who responded the best were the child that was before school age, under 6 years of age. So this is 6, 12 years, 18 years, and adults. So it can help adults. I don't want to say that it can help adolescents, but the ones that helps the best are the younger children. Okay. And this probably has to do with what we talked about earlier, how the brain has times when it can make changes better. We think that's why the children can respond better, but we don't know for sure. But that's what we think is the reason. Now, the reason why the government makes us do these placebo trials with the real drug is one, we've got to make sure that people want the medicine to work so bad that they think that it's working when it's not. So we have to make sure that nobody knows who's getting medicine. But the other reason is that we can now compare side effects that are related to the medicine itself. And the most common side effects that we run into is something called stomatitis, or these mouth sores. They get canker sores. Those definitely are caused by the medicine, but we have lots of ways to treat them if it's happening in a child or an adult, okay? Infections have been reported as a concern because, like I said, it's used in organ transplantation, it's used in cancer. But actually, the rates of infections in these patients taking these medicines is almost the same as patients who don't. I'll show you an example of that here in just a second. It does make a child's fat and cholesterol go up. It doesn't make them fat this way. It makes more fat in their blood. And if it's really bad, then we have to make steps to take tests. So that's why we do blood work in patients who take this medicine. We do it about 2 weeks after they start the medicine. We do it 3 months after they start the medicine, and then we do it every 6 months after that. And so we just need to monitor this and make sure that they're not getting too much cholesterol in their system. So this is what I wanted to show you about infections versus the mouth sores. The mouth sores we know are caused by the medicine. This is the placebo group who don't get very many mouth sores at all. These are the patients who are taking that medium dose or high dose. And you see that there's a big gap between these. This is a pattern that we say the medicine is causing this. We can deal with it, but it's the medicine that causes this. When we look at infections, though, you see how these lines are all traveling together? This is from us when we study this. This tells us that there may be a slight difference between those, but most infections are occurring just because they live and breathe and are human. It has nothing to do with the medicine. Because even the patients who didn't get medicine had the same observation. So we don't worry about infections nearly as much anymore. If somebody has a super high fever that we're even taking to the doctor or they need antibiotics, we stop the medicine until they finish their antibiotics and then they start the medicine again. But it's very easy for us to maintain that. But one of the things we find is that the longer a patient takes the medicine, their number of side effects actually go down each year. And that's true of whatever category, but here you see it with just all side effects combined. We said the longer they take that medicine, the less likely they are to have more side effects. So I showed you what it does for the kidneys. I showed you what it does for the lungs. I showed you what it does for the brain tumors. And now I've shown you what it does for epilepsy. I'm not going to show you, but there are studies that have shown that a cream can help the face. Okay. But I don't have that in my talk today. And then the last thing we do, well, what does it do for autism? And so we've started to work on this as how it can help in TSC. So what we did is we enrolled 50 patients who had either learning disabilities or autism. We didn't say you had to have all autism, but you could have learning disabilities or autism. And of those 52, some got placebo and some got treatment with Everolimus. And we ended up with 42 at the end. Now these were 6 years old up to 21 years old. So we didn't have any of the super young patients where their brains can maybe be more changed, okay? But we did older, and we did find a couple things. The Stockings at Cambridge is how well a child can make decisions. Saying I need to do this first before I do this. You and I do this all the time, where we make decisions. So they did better on making those decisions to solve problems. And they also did better on one of the measures of social, what we call social cognition, which is awareness of the situation. And so what this does is it has them make faces, and they have to interpret that face. Is this an angry face? Is this a happy face? Is this a friendly face? And they did better on that as well. But we had a lot of mixed results, where blue was where the patients got medicine, and red is the patients who got the fake medicine, the placebo. And you can see that some got better, some got worse, and this one they were more likely to get better. Same thing here. But it wasn't really dramatic. It was hard for us to say, out of all those things, those are only two things you can see that were better. But we've been able to do all these studies before in SEGA and kidney where the parents would tell us, well, my child is more alert, or my child is more interactive. But how do we capture that? That's the struggle we're having now, is how to do that in a study so that we can tell you exactly how your child's going to benefit and exactly who should be on medicine and who we can't help yet. And so right now we don't have more than that. But we did start to look at some of the other things, which we looked at. Well, what about the patients who have worse learning compared to patients who are very mild? Maybe that would help us see more. And indeed, we found that those patients who are worse got better in some areas, and those patients who have a very mild learning disability got better in other areas. So again, it goes to that complexity. Why is it helping some versus not others? Well, it's because we don't understand all the pieces yet. We're just trying to figure it out. We also looked at those who are younger compared to those who are older, and we found that there were some additional measures where there were differences according by age as well. So we think these are important factors. We have newer studies that we are trying to do now that are looking at specifically the younger patients and also specifically looking at those patients who have more severe symptoms. And so that's our next study that I don't have results for today, but tell you that we are working on this because it's worked in everything else at TSC. I firmly believe it's going to work for this as well, but I don't know how it's going to work, and I don't know how much it's going to be able to change. But I think it's going to change some things because I've had too many parents tell me that they've noticed differences. So we've made a lot of progress in the last 25 years where we identified these genes, we understood this pathway with mTOR. We did the first studies in patients in 2005 where we treated brain tumors. We got it approved for brain tumors. We got it approved for kidney tumors. We've got it approved for lungs. And we have, in certain countries, we have it approved for epilepsy, and we're hoping to get it approved in the U.S., but we don't have that yet. So this is just a summary slide of all the different ways we've used to treat it. The cardiac granulomatomas, we haven't done any studies, but there's lots and lots of published reports of patients, instead of doing a heart surgery as a baby, which is not usually required, but it does sometimes happen. There's probably now at least a dozen, if not 20 patients that have been reported in case reports or small series that say you can treat those heart tumors with mTOR inhibitors and shrink them instead of doing surgery. I talked to you about the neurological aspects, and the 2 checks means that we've done the definitive government-approved studies and shown that they work. There's not been any government-approved studies, but there's been a lot of case reports, and as I mentioned, now there's another study that will be published in the scientific literature this next month, showing that we can treat the face with creams and treat the facial lesions with that. The eyes, like I said, most times the eyes don't cause problems, but if you have one of those tumors in the eyes, it's been shown that those can shrink in response to these medicines. The kidneys, I showed you good examples of how we can shrink them in the kidneys, and I showed you how we can make the breathing better in patients who have LAM. So we've been able to do a lot with that with mTOR inhibitors, and we hope that we're going to be able to do more with the autism. And so you'll have to stay tuned that we're going to get there and get those proven that we can use it to treat autism. And then the question is, if it works for autism and TSC, will it work in autism outside of TSC? I think the answer could be yes. There's a lot of evidence suggesting that these are common pathways between the mTOR protein and what it does in TSC as far as autism and what it might be doing in other autisms. It's been linked to Fragile X autism. It's been linked to autism that's caused by another gene called P10. It's also been linked as possibly useful for a type of autism called Phelan-McDermott syndrome. Idiopathic autism, maybe even for that too, but that's going to be a harder nut for us to crack because we think there's a lot of different causes of that, and then we haven't figured out, maybe sort that out. So that's all I want to talk about, but I do think since it came up, can I show this slide on CBD?
Yeah, of course, yeah.
Okay. So I'm going to jump to what I shared with the doctors last night. We'll make you all doctors now. So it's been this is very much of interest in the United States, and I got to mention, since you brought it up, it has to be of interest to you guys here. We've known for at least 10 years, if not longer, that there's receptors in the brain that respond to treatment with cannabidiol, which is one of the main ingredients in marijuana. This is a type of one of the ingredients that doesn't cause the hallucination or the dependency effects. So what they did is they just took a lot of patients with really bad epilepsy and said, we're going to give you some cannabidiol, see if it's safe, and then also track your seizures. And what they found is as the patients started taking medicine, their seizures dropped. And they dropped quite significantly over time. And then the two seizure types that they treated, there were only like maybe, how many total patients was this? This was 140 and 2% of that. So this only had roughly about 4 or 5 patients with tuberous sclerosis. But they did have two other types of epilepsy that are just as hard to treat as tuberous sclerosis. One's called Dravet, and the other one's called Lennox-Gastaut. These are patients that have taken 10, 12 different medicines, and they have multiple seizure types every day. And they reduced their seizures by 30 to 40% in this study. Again, this is not an official study that the government would recognize, but it's one of them that sets the stepping stone so we can do those types of studies. And so they did that. This is the ones for Dravet, and they looked at convulsive seizures. And this is the patient's reduction. In this case, the higher is the better response. And we see that those patients with convulsive seizures or all types of seizures, each time it was the Dravet, the drug CBD patients that did better than those patients who got placebo. So this is actually at the US FDA right now, and we're hoping that in 2018 we'll get our first official approval for CBD oil in Dravet's. They also tested the other epilepsy that they had in the first study, which was Lennox-Gastaut. And they look here at drop seizures, and they also looked at total seizures, and also total seizures. Again, it was the CBD group that responded better than the placebo group. So what do we know about tuberous sclerosis? Well, there was one study that was done that we call open label in tuberous sclerosis, and involved, I forget how many patients, 200 patients. In this study, and it was several centers in the United States. And the graph is here, but here's the data, is that at baseline they were having 22 seizures per week. After 2 months of CBD, that got to 15 seizures per week, and they continued for a year, and they got it down to 8 seizures per week in the patients with tuberous sclerosis. So this is pretty exciting as well. And I know of cases where there's been a dramatic response. I've had other patients where there's no improvement. So it hasn't worked for everybody, but it's worked for some. And these are all patients where their previous medicines that they've tried a dozen different medicines without success. And so we got what we call orphan drug. That's a precursor for us to being able to get it approved in the United States. So this is the first step, was getting orphan drug designation. And then hopefully we get the actual regulatory approval to sell the medicine later this year. That compassionate use study is still ongoing, so it has 200 patients right now, and by invitation, so the patient can't go and say, I want to be in the study, but the doctors that are doing the study, if they have a resistant patient, they can start them on the drug. But now what they're doing is we have an open regulatory type study that started where they get either drug or placebo. And those results hopefully we have in a year or two. So I want to share that it's not just the mTOR inhibitors we're working on cannabidiol. We continue to do research in epilepsy surgery so to make the surgery get more successful. We are doing vagal nerve stimulation as well in these patients. So that's all I want to talk about there as far as new treatments and what we're trying to do as it relates to TSC as a whole, then epilepsy, because that ties so closely to autism, and then knowing that we are still working on the autism and we're pretty excited about that, and hopefully we'll have more results about that in the future. So that's all I got about new therapies.